All right, so we got feedback now from the three groups, and then I will do a little bit of summing up at the end in terms of next steps, because we're definitely not going to solve the problems by the end of this meeting. We've kind of defined the problems. So where's Gordon? Gordon's up first. Oh.
Yeah. So what I will do is I'll go through the stuff I think I heard.
So I think we had, is everybody here? So two topics or two questions to discuss. One is how to collect the data. And I think we all agree that our group will contribute. So we're going to go to general practice, data set, and inquire. And we're going to be writing to them with the help of charities. It's been done before, and that will hopefully enable us to compile a comprehensive list of patients who live in our areas. We're going to get some data from district nurses. Often they are involved in care of secondary progressive and primary progressive patients who are very ill and spend most of their time at home. We're going to approach rehabilitation centers and rehabilitation hospitals in order to get information from them about their patients. We would like to have a basic data sets or databases in our centers, but we are likely to engage with national programs like Optimize, which our center, we have assigned to that as well. We're going to look at HES data. They are readily available. But in terms of which particular part of the HES data, it will be emergency admissions, length of stay, but also reasons for stay in hospital. There is an alert software somewhere which alerts clinicians about patients who are being admitted. Is that correct? And then the reasons why they're being admitted to hospitals. So if our patients are admitted to hospital, then we'll be alerted about that. And I can't read number 10. Something about patient data satisfaction. I'm not sure about that one. So that's our data collection. I think that's probably all. Now the outcomes, probably more interesting one. So we had a longish discussion about the EDSS, and we said that despite all the shortcomings of the EDSS scoring system, it should be included. We're still required to do BlueTech forms. And again, I think there are issues about the walking ability, but then we could use some patient, what would that be called, Gavin, outcome tools, or in terms of the walking ability, so how do you call that? So something like that to kind of complement our assessments. Then we were talking about standardized clinical letter. So hopefully in the future we'll have a word identification tool, or software, which will pick up certain information from the clinical letters and put that in a separate database. So we said that we're going to have a paragraph on disease history. So first relapse, maybe second relapse, and the type of relapses, if possible. Obviously, many of these patients have been diagnosed many years ago, so that data is not available. Then we will have a paragraph about preceding 12 months in terms of relapses and any symptoms suggestive of secondary progression. We're going to have a paragraph about DMT history. Then we will have a paragraph about specific MS symptoms which need addressing at that particular point. A paragraph on neurological examination with EDSS score, and then finally management plan. So if the letters are standardized and each letter is written in such a way, then hopefully that will be a very important, useful source of information for the future once we have a better IT. We will capture relapses, obviously. That's important. We had a discussion about disease activity on the MRI, and hopefully in the future we'll have a software which will enable us to, say, measure a number of MS lesions, maybe even with a volume, and then maybe even look into assessing, let's hope, cortical volumes and whole brain volumes. But that's it's a bit of a wish list, obviously. We also wanted a biomarker in terms of. I think the candidates. The candidate number one is a neurofilament light chain in serum, but again, that will come in time. Then we were talking about smart technology, which will. I'm a bit confused here. So yeah, no, this is now we're talking about the access to services. So we need to devise clear referral pathways, and then risk assessments. So some sort of traffic light system whereby we will have a clear instruction to the GPs and to the consultant colleagues and peripheral MS specialist nurses, and devise a system whereby patients who are in clear need of being seen quickly are seen quickly rather than in the same basket of referrals you get with other patients who don't need urgent assessment. We were talking about lots of talk was about psychology and mental health services, and how do we access those, which scales do we use. I think we mentioned BICAMS as a potential tool we should be using in everybody. And then there's lots of discussion about smart technologies or variable technologies, and we haven't reached consensus which is the best one, but hopefully that will come in the future. Is there anything else here? And then, yes, I think we were talking about having a database of patients who are willing to participate in research trials, and Gavin gave us an example how it's been done in his hospital. Yeah. Yes, yeah. I think I've. Yeah. Now, I think in summary, I think this may sound like a wish list, and it may be a wish list. But we said that we're going to rank this in order of importance and priority. That's number one. Number two, we're going to introduce it gradually. So we're not very greedy, we're patient, so it'll happen in time. And then somebody has to have an ownership and be responsible for all this. Yeah. Good.
So that's a lot on that list. So to prioritize that list is going to take a whole other meeting, to be honest with you. Okay, David, you've got to take 10 minutes to sum up the...
Won't be 10. So what I'll do is I'll just give you a couple of examples, I hope, from each of the stakeholders. So we were asked to look at education. So we broke that down in terms of who, into patients, general practitioners, community teams, general neurologists, MS neurologists, and then somebody threw the press in right at the end. So I'm not really going to comment too much on that, but I'll refer you back to Jerry's excellent talk about affecting change. So in terms of the patients, I think we recognise that very much like a lot of the speakers have said, we may have to redesign services, partly out of necessity because of increasing numbers of patients and complexity, and partly through the benefits actually of group sessions. So we know that the team in Birmingham, for example, hold group sessions for patients with considering specific DMTs, and I think that gets a good press, and I think the patients find that helpful. So that may be something that we need to start considering in our own in our own services and redesign. There was a lot of discussion around Crimson, so obviously Helen's been involved with the MS Society in identifying factors that contribute to a decision aid, in this case for disease-modifying treatments, but presumably that type of methodology could be extended elsewhere. In terms of GPs, there was a lot of discussion actually about mutual benefit and mutual education. So MS specialist nurses holding clinics for patients in GP practices, and therefore making it more convenient for the patients, but also getting a return on investment, if you like, in terms of upskilling the primary care staff, and also where the primary care staff can upskill them. In terms of the GP educational programs, we thought that rather than simply badge things as a discussion around management of MS, we might make it more of a generic update in neurology, which would perhaps be more attractive to them, but also perhaps look at a problem-based approach. For example, you see someone with lower limb weakness, how are you going to assess this person? So we felt that might gain actually more mileage in terms of attracting the GPs to those type of educational events or opportunities. Again, same sort of thing in terms of the community teams working together for mutual benefit, really. In terms of the general neurologists, there were comments around the fact that some colleagues discharge the progressive patients back into the community. Sometimes, therefore, they're lost to follow-up and deleterious outcomes can occur. So one of the comments was to try and educate the general neurologists around referring the patients to the MS nurse rather than to discharge them. And we were talking about how we might do that and how we affect that change. And I think some colleagues have regular updates at their departmental meetings during the year. In terms of the MS neurologists, we touched on data. We touched on having metrics of our own practice and our own outcomes. We felt that perhaps we were illiterate in terms of asking the right questions in the right language to our IT colleagues in the trusts in order to effect the change that we want to effect. So there may be a need for us, if you like, to understand what data sources are readily available and the right way of asking for that data to be provided. So we think that that's a need. There was also a comment around more education around the psychiatric aspects of managing patients with MS, and there was also a comment around upskilling us in the recognising the increased numbers of young carers that there are out there. And that's a sort of very brief summary, but that's essentially where we were up to.
So we've got a lot of work to do on the education side. So that's also we need a group of people to work on that. Jeremy, are you up for it? Can you do it in 10 minutes?
Yeah, I should think so. I just got a text from Ben Bridgewater, actually. He said, should there be a vote at the conference on whether my professorship should be removed because of my footwear? He's a wag. So, I guess one key thing about the patient engagement group is we didn't have any patients in it. So that's the perspective of the people who were in the room at the time. I've tried to summarise this, and I have 10 points here, I think, and I've got my assistant who's going to prompt me with things that she may have noted. Okay, so the first thing in the kind of patient activation arena was clarity of the definition of activation and engagement, a structuring of the areas of engagement we think should be considered, and what good engagement looks like. So there's a little piece around that. Then I guess there's a piece of work around understanding from people with MS, and this may have been done, of what they think would help them to engage in the process that we've defined through this piece number 1. Then there's a piece around trying to understand why it is that there's a wealth of information out there through MS Society, MS Trust, various other scenarios, and why people don't access that information when it's available to them. So what are the reasons why people don't want to visit those informations? Is it because they don't know about them, which is an easily solvable problem, or is it actually that they don't wish to view and engage with those processes? There was talk about an MS Academy for patients. So the MS Academy taking on a process whereby they sequentially educate and develop a set of people who kind of have levels of, as it were, seniority or experience in as MS patients, and then they can disseminate that information through their localities. There was talk about the value of group-based clinics that may well be useful in terms of bringing people together so that there's an engagement with each other rather than on an individual one-to-one. There was talk that we should consider sending clinic letters to patients, not to their GPs. Now, we do some of that, certainly based on any results in MDT work, but actually I think that's a really great idea. I rather like that. Well, then there's something I can't read. There was an issue about that people's experience of the way the diagnosis is delivered to them is such a pivotal point in their journey that it's often a very negative experience in a much more destructive way than we may perceive. We understand that it's you're giving somebody a diagnosis of an incurable disease, but actually the way that information is conveyed can be profoundly destructive, and whether MS neurologists should undergo education programs or have advice and assistance and scripts or ways to help them develop those skills. And neither you and I have had any training in that area at all. So there was discussion about the importance of time and face-to-face interactions with people, that whilst there's a wealth of information around, that there's a shortage of time to enable people to build relationships and to enable questions to be answered, etc. So I guess the issue about that is, how do we create time for people? So how do we change aspects of our practice that mean that that frees up some of the time for these important early discussions? And then there was a kind of, I guess, a discussion around what Alistair Hignell talked about yesterday, was the processes, the stages that he went through before he was essentially at one with his diagnosis of MS, and whether we can, at the moment that seems to be more implicitly understood rather than explicitly defined, I guess, and can that be used to trigger various sorts of interventions? And I raised the point about whether that could be truncated, and there was a big pushback from the MS nurses that is not something that can be affected, the time to adjustment. Is that fair? Those are the points that I've got.
Yeah, I think they're pretty well covered. I mean, there was just to reinforce what you're saying, is what underpins a successful engagement.
Yeah.
Is something that needs to be maybe fleshed out. Do we understand it's a double negative, do we understand the lack of information and understanding? So the level of
that's
the lack.
right. Yeah.
Oh, was quite important. And I think the other bit was two more. Yes, can we formalise where a patient is in the pathway of coming to diagnosis, and how do we put people in the position of being able to access information.
Yeah.
But, and then the last bit was bit around expert patients and how do they function, so there was a one-stop shop in Huntingdon's to learn from.
Yeah.
I think Camilla made a point about learning from other disciplines. And then finally, my particular experience was back in the day when I worked in EMA expert patients, the AIDS community was formulated very much patient engagement and how that can successfully work.
So the idea of having that training course for people with the disease is a very good one. Okay, so we had feedback from all three groups, so that's good. So I just want to summarize, and I probably will do it in 10 minutes, so we can get out of here at 10:02, is, I've learned something, because the whole purpose of this meeting was on the assumption that variance was bad and was a euphemism for inequality, and I think I disagree with that statement now. I think variance may be bad, but it also may be good, and I think one of the messages was having variation and showing variation is a driver for change, because it means that there are people doing better than others, and because they're doing better than others, you can raise the standard. I think Ben Bridgewater made that point, is that he didn't get rid of variation when they put all those systems in place for cardiac surgeons. Everything improved, but the variation didn't go away. So it's not necessarily that important to get rid of the variation. You just got to acknowledge it as a force for change. I think in terms of defining one single objective, we can't really do that in 10, 15 minutes. So we'll come back to that. But I do think it's beyond DMTs. Everybody agree, the people nodded their heads. It's not about getting rid of variation in prescribing of disease-modifying treatments. It has to go beyond that. And it's looking at the whole MS pathway and everybody with the disease. So we have to improve outcomes for people with multiple sclerosis in general. Our targets are obviously disability long-term, but we should also not ignore the hidden aspects like the mental health, the social aspects, occupational aspects. And I suppose we will be moving to an area of wellness. I don't know if you saw in the BMJ last week, there was a new specialty formed. It's lifestyle medicine. And now there are people who are running courses to get yourself registered as a lifestyle medical expert. And so it'd be quite nice if we did that in MS as well. Because at the end of the day, it's not just about treating multiple sclerosis, it's about improving life outcomes. And so improving the quality of life. So we'll come back to the objective in terms of how we word it, and we'll obviously engage you at every step of the way, because you're now we're part of a group of people that are interested in this. And so the MS Academy will be a good umbrella organization to do this. I think another message that came out is transparency, making this data and everything linked to this data open and in the public domain, so people can look at it, and we can then prevent freedom of information requests. Maybe we can get rid of some of the freedom of information requests. I think it's important. Clearly, the other thing that came out is partnerships. So this is not going to be done by one group of people. It's going to be done by many groups of people. And unofficially, NHS England are on board. Both Jackie Kemp, who is the Neuroscience Commissioner, Malcolm Quayle said he's prepared to consider business cases or proposals to change the guidelines, to change the Blue Tech form, actually even to use the Blue Tech form as a form of a register. He said he's up for that. So we could go back to him later on with demands, and he's prepared to accept it. And he's not all bad. Malcolm Quayle, he's often portrayed as being all bad, but I think I saw a very human side to him today. Didn't you see that? He does care about, he cares about patients. Despite having to look after the billions of dollars of NHS England spending, he does think about patients. So I don't think he's just there to stonewall us. I think he's a true partner. And then obviously with the charities and the third sector organizations like the MS Trust, MS Society and Shift MS, they're also on board in helping us make this work. So it's about partnerships. Obviously, we're going to have to take this forward. So we defined 3 streams. The four of us over lunch defined the 3 streams that we think need further work: the data, the education, and the patient activation. And I think we're going to have separate repeat meetings for that. And this is where I need everybody to throw their names into a hat, because if you want to be involved, and we'll send around a survey or a request for you to come back to us if you want to be involved and actively involved in helping make those subcommittees work, to be honest with you. Because there's no way we can all do this from the top down. It has to be done from the bottom up, which also involves setting up like a much bigger steering committee with more diversity. Okay, the mistake I made was that there are 4 males. And we all had this discussion in a pub after a debate at the ABN. So we all need to get together. And so I'm asking people who want to be involved, please come forward. Then which umbrella organisation? So the MS Academy, I think, is ideal to do this because we're not linked to any specialty or any group of people. You know, most of the organisations that exist are there for specific people, like the pharmacists, for example, won't have non-pharmacists. The ABN is just for neurologists and associate specialists. MS Trust is de facto the MS No Specialist organisation. And I don't know if neurologists can join the MS Trust, you know, etc. So, you know, if the MS Academy can become like the British Society of MS Healthcare Professionals, and that could also include MS patients, people with the disease, because at the end of the day, they're also experts. So we could, there'd have to be some kind of ring fencing between the two groups because of ABPI rules, etc. But we could almost certainly make it happen. So the fact that you're all now registered with the MS Academy, all the stuff will go through the MS Academy website. So if you want any information, please feel free to do it. And if we do have any further meetings, it'll almost certainly be under the MS Academy umbrella, which is why I want to thank them for putting this together. So Sarah, Jamie, Charlie, Jackie, who have I left off the list? Then we've got to thank the sponsors, Roche and Biogen, who are the platinum sponsors, as well as Sanofi Genzyme, Merck, and Novartis. This meeting didn't happen without funding, and so we've got to appreciate it. It'd be nice to do these meetings without pharmaceutical funding, but it's just in the current climate, it's very, very difficult to do these things. Also like to thank the endorsers, MS Trust, MS Society, and Shift MS for supporting this meeting, because I think we all want this initiative to be successful. I must thank my co-chairs for sending out enormous numbers of emails to try and invite people. It was a bit of work. We tried to do it one-on-one, personal emails, invites to make people feel that they were. And I think we got representation from, is it 48? Just shy of 50 treatment centres across the country, which is pretty good because I think there's only about 85 nationally. So we've got very good representation, yeah. I agree we do need more involvement from the other home countries, but initially this was all driven by BlueTech, to be honest with you, and the NHS England treatment guideline. That was the initial stimulus for this, but it's clearly beyond that now. And then I want to thank the speakers for their contribution. I think they generated very good discussion. We didn't have enough time to discuss things properly, so maybe next time we will do less speakers, more discussion time. And I would like to leave it at that, so people can get downstairs and get their taxis.
I would like to thank Gavin for being a driving force behind.